Hello Dentospedia learners. In today's case study, we'll discuss localized aggressive periodontitis, a high-yield topic for all dental board exams. We'll move step by step: history, findings, investigations, questions, and exam tips. Here is your clinical scenario for this case study. Refer to this information for questions 1 to 5. Mr. John, a 58-year-old male, attends your clinic complaining of painful gums and loose teeth. On further questioning, you learn that John has a 20-year history of poorly controlled type 2 diabetes mellitus and smokes 15 cigarettes per day. He reports that his gums bleed spontaneously while brushing, and that chewing tougher foods has become difficult. He has not visited a dentist in over 8 years. His medication history includes metformin and insulin. No known drug allergies. Let's have a quick breakdown of the patient's profile: age, gender, chief complaint, and medical history. On examination, the gums are inflamed and bleed on brushing, with halitosis and tooth mobility in the lower anteriors. Probing shows multiple deep pockets, and radiographs reveal generalized horizontal bone loss, with vertical defects near the molars. Now that we've reviewed the case history, findings, and investigations, let's test ourselves with some interactive questions. I'll show you the question with 4 options, give you a few seconds to think, and then we'll reveal the correct answer with explanation. Question 1. What is the most likely diagnosis in this patient? Options. Option A. Chronic gingivitis. Option B. Localized aggressive periodontitis. Option C. Generalized periodontitis. Stage 3. Grade C. Option D. Necrotizing ulcerative gingivitis. Take 10 seconds to think. The correct answer is C. Generalized periodontitis. Stage 3, Grade C. Why? Because this patient is middle-aged, has severe generalized bone loss, deep pockets, and key risk factors like smoking and uncontrolled diabetes. That fits Stage 3 for severity, and Grade C for rapid progression. Other options? Gingivitis doesn't cause bone loss. Localized aggressive periodontitis occurs in teenagers, not 58-year-olds. NUG presents with necrotic papillae and pseudomembrane, which we don't see here. Question 2. Which risk factor most strongly contributes to disease progression in this case? Option A. Poor oral hygiene. Option B. Smoking. Option C. Age. Option D. Stress. Think for a moment. The answer is B. Smoking. Smoking is the single biggest modifiable risk factor for periodontal breakdown. Why not the others? Poor hygiene contributes, but bone loss here is much greater than plaque levels suggest. Age is not a cause, just cumulative exposure. Stress is a minor contributing factor, not the main one. Question 3. What is the first step in managing this patient? Options A. Periodontal flap surgery. Options B. Extraction of mobile teeth. Options C. Scaling and root planing with oral hygiene instruction. Options D. Antibiotics only. The correct answer is C. Scaling and root planing with oral hygiene instruction. This is phase 1 therapy. Reduce bacterial load, control inflammation, and improve patient hygiene before moving to surgery. Why not the others? Flap surgery is only after phase 1 extractions come later, only if teeth are hopeless. Antibiotics are never the first step, they're just adjuncts. Question 4. Which surgical option is best for vertical bone defects around first molars? Options. Options A. Gingivectomy. Options B. Guided tissue regeneration. Option C. Apically repositioned flap. Options D. Gingival curettage. Think for a moment. The correct answer is B. Guided tissue regeneration. Vertical or angular bone defects respond best to regenerative procedures, especially GTR with barrier membranes, sometimes combined with bone grafts. Why not the others? Gingivectomy is for gingival enlargement. Apically repositioned flap is for crown lengthening, not regeneration. Curettage is outdated with minimal benefits. Question 5. What is the prognosis if smoking is not ceased and diabetes remains uncontrolled? Option A. Excellent, with maintenance. Option B. Guarded to poor, disease will progress. Option C. Good, if antibiotics are used. Option D. Same as a healthy patient. The correct answer is B, guarded to poor. Without controlling risk factors, even the best treatment won't stop progression. Tooth loss is almost inevitable. Why not the others? Excellent or good prognosis isn't possible here. Antibiotics give only short-term improvement. And the prognosis is definitely not the same as a healthy patient. For Mr. John, we start with oral hygiene instruction, then scaling and root planing. Antibiotics like amoxicillin and metronidazole may be added. Re-evaluation is done after 6 to 8 weeks, and systemic control of smoking and diabetes is essential for long-term success. In Mr. John's case, the prognosis is guarded to poor if smoking and diabetes remain uncontrolled, but with strict oral hygiene, supportive therapy, and systemic control, the outcome can improve to fair or even good. Let's wrap up with some quick Dentospedia clinical pearls. First, always use the 2017 AAP-EFP classification to stage severity and grade progression in periodontitis cases. Second, remember that smoking and poor glycemic control are the strongest risk factors for rapid breakdown. Third, scaling and root planing with oral hygiene instruction is always the essential first step before considering surgery. And finally, long-term success depends on systemic control. Without quitting smoking and managing diabetes, no periodontal therapy will truly last. Follow us on social media. Download our app Dentospedia on Play Store and App Store.